Endocrine pharmacology. All right, so for endocrine pharmacology, it's relatively straightforward. All you have to know is the diabetes drugs. Once again, you have to watch the videos on Sketchy in order to fully understand everything that is important, okay? I'm just gonna go over this relatively quickly. So for diabetes, right, type 1, you're mainly gonna treat the patient with insulin replacement because type 1 diabetes is you have decrease in production or complete loss of production of insulin. So you just have to give them insulin, right? And so there's multiple types of insulin. Now you have to understand the different types. The first one, Lispro, Aspart, and glucosamine, okay? Lispro is the most important of those three, and these three are all rapid acting, okay? Rapid acting. And all that it's going to do is that it's going to peak up really early, and usually they're going to give it to patients like right before they eat or like right after they eat, okay? So it's rapid acting real quick, gets out of your system after, okay? Works relatively quickly. Next is short acting. Short acting is just regular insulin, all right? This is the only one that we give via IV. It's just regular insulin, okay, that is found in our bodies. Next is intermediate, which is NPH. Moving on is long acting. And long acting, the most important one is glargine. Okay, glargine or glargine. Glargine or glargine, okay? Same thing. They are long acting insulin. Now, what does that mean? That means that you can take it in the morning and it just lasts throughout the whole entire day, okay? Now, to reproduce physiological insulin release in patients that are type 1 diabetics, what they do to approximate it is they'll have a patient take a glargine once daily in the morning, okay? Plus Lispro, the short acting, or I should say rapid acting, before each meal. So they'll take like Lispro before every single meal, before breakfast, lunch, and dinner. And then right before breakfast in the morning, right when they wake up, they'll take glargine, which lasts all day, all right? With all these insulin preparations, there's no C-peptide increase because remember, these are all exogenous. Lastly, for glargine or any insulin, honestly, you have to remember that when giving beta blockers with insulin, it's going to mask the effects of hypoglycemia, okay? So keep that in mind. Beta blockers are going to mask hypoglycemic events. So let's say a patient took too much insulin, but they're also taking beta blockers, and they come to the hospital with really, really low levels of glucose in their blood. And the question might be, well, why is the patient completely able to move around and act normal and they're not presenting with symptoms of hypoglycemia? Well, the reason behind that is because they took beta blockers. Beta blockers is masking that effect in the symptoms and signs of hypoglycemia. So keep that in the back of your mind. If a patient presents with like 40 of like their serum glucose levels is like 40, they're severely hypoglycemic, but they're not presenting like a normal hypoglycemic patient with the signs and symptoms, they're probably taking beta blockers, all right? Good. Now, the number one adverse effect of all these insulin preparations are hypoglycemia. Makes sense, right? If you take too much insulin, you can have a potential risk of going into hypoglycemic state, all right? Very important, very straightforward. That's how you treat type 1 diabetes mainly, insulin replacement. Cool. Moving on to type 2 diabetes treatments. Type 2 diabetes treatment is a little bit more difficult. The reason behind that is because we do have insulin production, mainly, majority of the time, but we have a decrease in sensitivity of that insulin, okay? So we have to find different ways to help that out. So the first one that we have to know, that the first line for type 2 diabetes is metformin. And what metformin does is that it increases insulin sensitivity. And the way that it does that is by inhibiting mitochondrial glycerol 3-phosphate dehydrogenase, MGPD. All right, and that inhibits, what you actually have to know, it inhibits hepatic gluconeogenesis and the action of glucagon. Okay, that's first and foremost. You have to know metformin is the first line for type 2 diabetics. They will ask, what's the first line for type 2 diabetics? Easiest question here in the world. Metformin. What does it do? It increases insulin sensitivity. How does it do it? It inhibits hepatic gluconeogenesis and the action of glucagon by overall inhibiting MGPD. Well, what are the adverse effects? GI upset, lactic acidosis. So you have to use with caution with renal insufficiency. Okay, so before I give metformin, I have to check creatinine levels. Why? Because if I have high levels of creatinine, that tells me I have some type of renal insufficiency, and that can lead to potential lactic acidosis. So check creatinine levels to avoid lactic acidosis in metformin patients. It also can cause, it's one of the drugs that causes vitamin B12 deficiency. You'll see weight loss, which is often desired with metformin. All right? But the main game is increased insulin sensitivity. Another drug that increases insulin sensitivity that can be also used is thiazolidinediones, okay? Mouthful, but TZDs. It's also known as pioglitazones, okay? And they'll say the glitazones or the TZDs. Now, these increase insulin sensitivity just like metformin, but they're not first line. How do they increase insulin sensitivity? They activate PPAR gamma. Very important. This is a nuclear receptor. And since they activate PPAR gamma, that means they're going to take a little bit longer, okay? Because they are acting on the nuclear receptor. So they're changing transcription and translation. This overall increases insulin sensitivity and levels of adiponectin. They like to ask about that. All right. You're going to see weight gain with this. They love to ask about weight gain. And you're going to get delayed onset of action for several weeks, as I said, because it acts at gene transcription levels from the PPAR gamma. Very important. You also have an increased risk of fractures with these glitazones or TZDs. Okay, so weight gain and heart failure as well is an adverse effect, as well as fractures. Next, we're going to look at the drugs that increase insulin secretion. So maybe instead of increased insulin sensitivity, we could try to increase insulin secretion, and this will help us with type 2 diabetes, okay? There's two types. You have the sulfonylureas and the meglitinides, okay? Sulfonylureas, there's first generation and second generation. The only difference between the first generation and second generation is that the second generation doesn't have an alcohol reaction, okay? So with the first generation sulfonylureas, they have a disulfiram-like reaction, and they'll tell you, hey, this patient came in after a party, they had a couple glasses of wine, now their face is flushed, they feel really hot. That's called a disulfiram-like reaction, and they're going to ask you what drug they took, and one of the drugs that they could have potentially taken was sulfonylureas first generation, and those are known as chlorpropamide or tolbutamide, okay, and those are amide drugs. They end in AMIDE. Okay, those are one of the drugs. There's also other drugs that we'll talk about later on that can cause disulfiram-like reaction with alcohol ingestion, but this is one of them. It's first generation sulfonylureas. Okay, they rarely use them anymore. They just give them sulfonylureas second generation just because they don't want patients to have this reaction. Meglitinides also, okay, these are non-sulfa drugs. Sulfonylureas are sulfa drugs. So this is something that you can give patients that have sulfa intolerance or they're allergic to sulfa drugs, right? These end in glinides, okay? GLINIDE. So these are meglitinides. They're the same as sulfonylureas, same mechanism of action, but they're just non-sulfa drugs. Now the question is, what's the mechanism of action? Well, they close the potassium channels in the pancreatic beta cell, which leads to cell depolarization and an increase in insulin release, right? Well, what did we say? How do we normally release insulin in a patient that doesn't have any problems with this process? Well, we said that there's going to be a rise in ATP due to the fact that glucose enters via GLUT2. The rise in the ATP secondary to the glucose leads to a closure of the ATP-gated potassium channel. The closure of the ATP potassium channel is going to depolarize the cell, causing calcium influx and an overall release of insulin. Well, all sulfonylureas and meglitinides do is they're going to just close that potassium channel without ATP needed. And so that leads to depolarization immediately and an overall increase in production of insulin. So these drugs don't increase insulin sensitivity, they increase insulin production. And this is endogenous insulin production. So what will you see with the C-peptide levels? You'll see an increase in C-peptide because this is endogenous increase in insulin production. Okay. Once again, the adverse effects is disulfiram-like reaction for the first generation sulfonylureas, and then hypoglycemia is also a risk because you're increasing the total amount of insulin being produced endogenously. All right. Next is let's maybe increase our glucose-induced insulin secretion. So what does that mean? These are our incretins, our GLP-1s. So what we have is GLP-1 analogs, okay, we can give, or DPP-4 inhibitors. So GLP-1 analogs are just like GLP. And what does GLP do? GLP increases the amount of insulin by a lot when we have oral glucose entering our body, okay, right? That's why we have such a large spike in insulin when we have it orally, when we take oral glucose compared to IV glucose, because we have GLP that rises and allows for the spike in insulin when oral glucose is sensed. So even without oral glucose, we could give them GLP-1 analogs to spike that insulin. So you're going to see an overall decrease in glucagon release, a decrease in gastric emptying, and an increase in glucose-dependent insulin release, right? Makes sense. And these are drugs that end in TIDE, TIDE. And the way that me and all my buddies remembered it is that this is Ozempic, right? This is the drug that Ozempic is known for. I mean, it's huge in the news. This is the common weight loss drug, okay? The most common weight loss drug now. It's booming. And so the way we remembered it is that Ozempic, which is a GLP-1 analog, changed the tide of the world, okay? It changed the tide of the world. And so they end in TIDE, right? Because it's such a great, powerful drug. It's doing amazing things for people. All right, so obviously adverse effects is going to be weight loss, but it's often desired, right? And then pancreatitis. They love to ask about pancreatitis for GLP-1 analogs. So keep that in mind. And then the DPP-4 inhibitors. Well, what happens is that DPP-4 enzyme normally deactivates GLP. Okay? So if we inhibit DPP-4 enzyme, then we have increased levels of GLP. Okay? So we're blocking that inhibitor of GLP, leading to increased levels of GLP, which once again leads to decreased glucagon, increased glucose-dependent insulin release, and an overall decrease in gastric emptying. Okay, so DPP-4 inhibitors. These end in gliptins, all right? Next is decreased glucose absorption. This is our SGLT2 inhibitors. We already talked about them. They end in flozin, Flozin. These block reabsorption of glucose in the proximal convoluted tubule, the PCT. Okay, they cause osmotic diuresis, and they can also lead to decreased blood pressure, right? This is helpful because specifically for patients that have heart failure, this is a mortality, right? It increases or decreases our mortality. So very, very important. It also decreases our glomerular hyperfiltration and renin production. It's very, very important for us. But it causes glucoseuria, which makes sense, right? You're not reabsorbing your glucose anymore. You're just peeing it all out because you have so much glucose in the body secondary to type 2 diabetes, all right? Another one is alpha glucosidase inhibitors, acarbose or miglitol, sorry. Don't confuse those, acarbose and miglitol. These are surprisingly high yield. What happens is they inhibit intestinal brush border alpha glucosidases, meaning that you can't absorb glucose at the intestines. All right, that's all they do. They block the absorption of glucose at the intestines by inhibiting intestinal brush border alpha glucosidases. Now, the reason you might be asking, why is this high yield? Well, the vignette, the classic vignette that they love to present with is that patients will come in, they're severely hypoglycemic, and they're like, Doc, I've eaten a chocolate bar, I can't get my glucose levels up. And then they give them orange juice, they give them juice, something that's really high in sugar, and they still can't get their levels up. And then they ask you, what did this patient take? And they're expecting you to put this answer, right? This is the easiest answer. The patient took one of these two drugs, right? Acarbose or miglitol. And it makes sense because even if they're eating chocolate or they're drinking orange juice, high levels of sugar, it's not getting to their blood because those drugs are blocking the absorption of glucose. Perfect, easy, straightforward. Moving on, I'm not going to talk about pramlintide. It's not important. Next is the thyroid drugs, okay? The first one that we have to talk about, PTU and methimazole. We already know PTU and methimazole, their mechanisms of action, okay? They're going to block thyroid peroxidase. They both block thyroid peroxidase, okay? But PTU also blocks 5' deiodinase, okay, which leads to a decrease in peripheral conversion of T4 to T3, right? Now, why do we only use methimazole? Essentially, it's because PTU has a very, very adverse effect on the liver. It causes hepatotoxicity, okay? But we only use PTU in first trimester of pregnancy because methimazole can cause aplasia cutis. It's a teratogen, okay? We use it for hyperthyroidism. So we're going to block TPO, which is like the main enzyme that helps with organification, coupling of iodine, leading to production of our thyroid hormone. So we're going to block that process. So we're going to help use it. It's a clinical use for hyperthyroidism, all right? This cannot treat Graves' exophthalmos. You have to treat that with glucocorticoids, right? Last thing, both of them cause agranulocytosis, which is rare, but it decrease in neutrophils. So if a patient is like sick, secondary to this, start thinking about that. Next is levothyroxine or levothyroxine. Levothyroxine is just T4 and T3, okay? Levothyroxine is T4, levothyronine is T3, okay? This is gonna be used for hypothyroidism. That's like literally the only usage for it. And there's really not much that you really need to know about it, but levothyroxine use can lead to decreased serum levels of thyroglobulin levels, okay? That's all that you have to know, all right? And decreased absorption can occur of levothyroxine if you're taking, once again, iron and antacids, all right? Hypothalamic and pituitary drugs. The Vaptan drugs are V2 specific ADH antagonists. So they're going to be used for SIADH. They block the action of ADH at the V2 receptor, okay? Very, very important. You have to know that. Demeclocycline is ADH antagonist. It's a tetracycline as well, and it's also used for SIADH, not as high yield. Desmopressin, we already talked about it as an ADH analog. It's V2 specific as well. It can cause hyponatremia, right? Because it's an ADH analog. And it's used for so many things, essential diabetes insipidus, von Willebrand disease, and also hemophilia A. It could also be treating esophageal varices. All right? Once again, I'm flying through these. Keep these in mind. Somatostatin analog is octreotide. You can use these also for esophageal varices, but we talked about it for glucagonoma, gastronoma, carcinoid syndrome, and acromegaly. Cinacalcet, all that it does is it sensitizes calcium sensing receptors, leading to an overall decrease in PTH. So what it does is that at the parathyroid hormone, or at the parathyroid, it's going to say, hey, like if I were to need maybe like 5 molecules of calcium, I'm just using random numbers, normally 5 molecules of calcium will help me inhibit it and make the negative feedback loop worth it, okay? But cinacalcet, what it's going to do is going to say, hey, I only need 2 molecules of calcium in order to inhibit PTH production. And so that's what cinacalcet does. It leads to an overall decrease in PTH. So that's why we use it for hyperparathyroidism. Very important in patients with CKD, all right? Lastly is sevelamer, not as important, but all it does is it prevents phosphate absorption from the GI tract, and it's used for hyperphosphatemia seen in CKD. That's it. That's all for our endocrine pharmacology. I know I ran through that. The most important drugs you have to know is our diabetes drugs. You're going to watch the videos on them. The type 2 diabetes drugs are very important for your understanding, both in the clinical field as well as for the exam. So make sure you understand them. Watch those sketchy videos, put it in your Anki, and keep up with those. All right? That's all for the endocrine system. Moving on, we'll be talking about repro.